Good evening, everyone, and thank you so much for joining on our monthly cardiovascular disease prevention seminar at DEBAKEY Studio Live. Just some housekeeping before. If you have questions during our presentation, send it us. You can join it by web. Go to paulev.com. Enter DEBAKEY, respond to the activity, or you can also do it by text. Text DEBAKEY to 37607 and then text in your message. So today we're talking about cardiovascular disease consideration in pregnancy. As we have made great strides in reducing the overall cardiovascular mortality over the last 2 decades, at the same time, we are witnessing a new phenomena, a rise of cardiovascular disease in the young. Now, particularly troubling, and I guess in an area which is extremely we are underprepared, is how to deal with cardiovascular disease risk and the disease itself among pregnant women. It's truly sobering that it still remains the leading cause of indirect maternal mortality. For example, cardiovascular disease, if you look at the numbers, is the leading cause of pregnancy-related mortality in US. And over the last 3 decades have almost doubled. Now, hypertensive disorders of pregnancy are pretty common in the US, so we see them often occurring almost 1,000 per 10,000 delivery hospitalizations. Lipids, total cholesterol, triglycerides, LDLs, we know they rise steadily during pregnancy and reach peak level at the time of delivery. And now we are doing more screenings and seeing many patients during pregnancy seeking help for disorders. Now, not many of you would be aware of the pregnancy-associated myocardial infarction. It accounts for almost 1/5 of maternal cardiac deaths. And among that, just the spontaneous arterial dissection being a cause of 1/3 of these cases. Clearly, these are critical issues with less generalized guidance. I think we have less understanding on what the best practices are. So to disentangle some of these issues, today I'm truly honored to have 3 very special guests, women in cardiology leaders who have truly championed and are shaping the direction of cardiovascular health and prevention among pregnant women in the US. First, I'd like to introduce Dr. Laxmi Mehta. She is Professor of Medicine, Director of Preventive Cardiology and Women's Cardiovascular Health at the Ohio State University Wexner Medical Center. Second, delighted to have Dr. Marysia Tweet, Assistant Professor of Medicine at Mayo Clinic, Rochester, and Senior Consultant there. And dear friend, Dr. Garima Shah, Assistant Professor, Director of Cardiac Ops Program at Johns Hopkins Hospital and Ciccone Center for Preventive Cardiology. So in this format, we'll have first Dr. Laxmi Mehta speak about lipid obesity management in young women who are desiring pregnancy, and followed by a short discussion by Dr. Marysia Tweet on the issue of SCAD and pregnancy, and then closing up with Dr. Garima Shah talking about adverse pregnant outcomes and long-term impact on cardiovascular disease. And then we'll open up the floor for more general discussions. So without ado, Dr. Laxmi Mehta, thank you so much for joining us today.
Thank you, Dr. Nasir. Can you see my screen?
We can see your notes screen if you want to enlarge that to...
Oh, sorry.
Not a problem. If you go and have the full screen, that would show up.
How's that?
Yeah, that's perfect.
Perfect. Sorry about that. So today I was actually going to talk a bit about familial hypercholesterolemia in pregnancy, as well as what the lipids can look like in pregnancy, as many patients may have lipid disorders that aren't recognized yet, have no disclosures to report. So before I begin, I think it's important to recognize that FH is one of the most common life-threatening familial disorders. It's autosomal dominant. And in this NHANES data, the estimated overall US prevalence of probable or definite FH is 1 in 250 people. So very prevalent, but you have to look for it. They've shown that the FH prevalence was similar in men and women, and that more often you can see it in obese versus the non-obese population. But it's also estimated that 90% of our FH carriers are still undiagnosed. And so if you're taking care of a female who's desiring to get pregnant, you may not even know that she has FH. And so recognizing and screening for it is essential. Furthermore, we need to recognize that so what if they have hyperlipidemia? Well, the problem is that these patients can have early atherosclerosis. So you can see in this depiction a 95% stenosis in a young patient. And we know that as the LDL levels rise, and those with an FH mutation tend to have higher levels of odds risk for coronary artery disease. And this is where women are disadvantaged, because when you're at a younger age, even if you're diagnosed with FH or have high LDL levels, practitioners tend to shy away from treatment due to the fear of affecting fertility or the potential fetal complications if the patient unexpectedly became pregnant. And that becomes a detriment for females. So if we shift and look at LDL levels or lipid levels, they do vary during pregnancy, and it's important, but it shouldn't preclude you from testing lipids during pregnancy. So in this study of 8,700 women who were monitored, who had their lipids monitored pre-conception, during pregnancy, and after pregnancy, you can see that after conception, there's a slight decrease in the total cholesterol, LDL, and triglyceride levels, and it naters at about 2 months, gestational months, and then it increases to a steady rise throughout the rest of the pregnancy and peaks at near term. These cholesterol levels are important for the fetus, but what we also recognize is that these patients do have a drop in their lipid levels following conception. And so it's important to test these patients. So when we think of the cumulative LDL cholesterol burden and what does it matter in a young patient, the fact is that as the cumulative LDL increases throughout their lifespan, their risk or threshold for developing coronary heart disease increases. And in a normal patient, with a cumulative LDL cholesterol burden in a 55-year-old patient, their level would be at 160 millimoles. But if you had a patient that had heterozygote FH, if they were left untreated, they could develop coronary heart disease at the age of 35, versus if they were treated at age 18, they may develop coronary artery disease a little bit delayed at 48. And but those that are homozygous may develop coronary artery disease at 12.5 years. And what this is important to recognize and shows is that these women who are treated here at who are not treated at these younger levels are going to develop coronary heart disease at an earlier age, and why we need to institute treatment. And even before they are attempting to get pregnant, you need to do it in their teen years as well. And talk to them, though, about the risks of pregnancy and what they need to do, and having those close conversations with you before getting pregnant. So how do the lipid levels of an FH patient differ from someone who does not have FH? When we look at this, as I showed, there's a slight increase in LDL cholesterol in a non-FH patient, but in those with FH, when you put them on a statin, their LDLs drop, and then they increase when you stop the statin, and throughout pregnancy, there's a relatively absolute higher increase in their LDL levels, making them at higher risk. So what do we do with these patients that are thinking of getting pregnant? Well, typically we would say that statins are going to be contraindicating during pregnancy and lactation, and so are many of our other treatments, such as ezetimibe, niacin, cholestyramine, the PCSK9 inhibitors at this time. And so women really need, with FH, need counseling on risk reduction and management, including the lifestyle treatments that are necessary. So when a female with FH or even secondary prevention of coronary disease is thinking about getting pregnant, they need to have those close discussions with you as a provider, and need to come off the statin, ezetimibe, and niacin at least 4 weeks prior to discontinuing their contraceptive methods. Now, there's some women who may accidentally become pregnant while on statin therapy, and there are some teratogenic risks, but the likelihood of that is still low. And at this point, the only medication that's currently acceptable during pregnancy are bile acid sequestrants. And as you know, bile acid sequestrants do have their GI effects and don't really lower cholesterol as effectively as we like. There is data on a PCSK9 registry data that's prospectively collecting observational registry data to look at outcomes in women who were exposed to the PCSK9 during pregnancy but not that they're promoting to give it in pregnant women. It's also important to recognize that women with FH can have other conditions that can impact them, and such as like hypertensive disorders that Dr. Sharma is going to talk about. Additionally, some of the FH women do receive fertility treatments, and so they need just those kinds of close discussions with their cardiologist or their lipid specialist about their cholesterol and triglyceride levels while they're trying to get on fertility medications as well. And another important area is lactation. You know, we want to encourage our women to nurse their children. At the same time, it does delay getting them back on effective treatment. And so having that discussion of what is the best amount of time to nurse is also essential. And then as soon as they're ready to stop, is getting them back on their intense treatment is also important. And there's some patients that may require LDL apheresis during pregnancy. So it's important to know that FH can be managed safely during pregnancy. It does require close monitoring. It does require close monitoring with the lipid specialist as well as labs. Having that cardio-obstetrics team is important, working with the obstetrician. Stopping the statin is important, getting women on bile acid sequestrants. And then resuming the statin after breastfeeding is essential in these women. So with that, I'll end, Dr. Nasir, and I'll give the share back to you guys.
Dr. Mehta, thank you so much for this overview, fantastic insights, and of course will generate a lot of discussion. So now handing over to Dr. Tweet, look forward to your thoughts on SCAD and pregnancy.
All right, can you see my screen now?
Yes, we can.
Thank you. I'm so very happy to be here to talk. Thank you for inviting me. I'll be focusing on SCAD and pregnancy. So just to make sure we're all starting from the same page, SCAD is a cause of acute coronary syndrome due to an intramural hematoma or a tear within the coronary artery wall. Mostly occurs in women in current series up to 80 to 90%. The average age of SCAD occurs at age 42 to 52 years of age, depending on the registry, but patients can be as young as 14 or older than 70. Up to 80% might have fibromuscular dysplasia or other arteriopathies, and anywhere between 5% to 18% of patients have SCAD associated with pregnancy. And as already mentioned, SCAD is one of the major causes of pregnancy-associated myocardial infarction. This is just an example of a 34-year-old female presenting with a STEMI at 9 weeks postpartum. And I'll just highlight for you the intramural hematoma at her left main and proximal left anterior descending artery. During the catheterization, this dissection propagated where she lost flow to her LAD, as you can see here. And then it was obvious that the tear had extended throughout the left main, as shown here in those blue arrows. So what about coronary dissection? Let's go into this a little further. So if we just look at pregnancy-associated dissection, there's a nice article published in the European Heart Journal looking at the nationwide readmissions database. And they found that any arterial dissection occurred in about 5.5 of 100,000 hospitalized pregnant or postpartum women. This most often occurred postpartum, and the most common location was coronary artery dissection. There was a nice study done by Dr. Havakuk and others, including Dr. Yuri Al-Khayyam, that did a literature search for published pregnancy-associated SCAD cases. This group identified 120 published cases, and many of these patients presented with STEMI. A lot of them were postpartum. 72% had LAD involvement. 36% had left main involvement, very similar to the case I just showed you briefly. 40% had multivessel SCAD. And also 44% had a left ventricular ejection fraction less than 40%. Maternal mortality and fetal mortality was not benign either. Now, I'll mention that these were published cases. There's likely a publication bias. You know, journals are interested in the cases that are complex and what have you. So we do have a Mayo Clinic SCAD registry, and in 2017, we looked at that registry, which again has some selection bias based on those who decide to participate. But we did identify 54 pregnancy-associated SCAD patients compared to 269 non-pregnancy-associated SCAD patients. And again, we found, consistent with some of the other findings I presented to you, that pregnancy-associated SCAD patients compared to others who had SCAD more likely had STEMI, more likely had left main SCAD, more often had multi-vessel SCAD, often presented with a lower ejection fraction. Interestingly, they were less likely to have fibromuscular dysplasia. And these patients tended to be older than 30 years at the time of their SCAD, multi-parous, had a history of infertility treatments, or preeclampsia, which all are hypothesis generating. The mean age was 35 years. 4 were actually pregnant at the time of their SCAD, but the majority were actually within the 12 weeks postpartum period. There was 1 who had a miscarriage and 1 who had a stillbirth. But when we look at the 48 women who delivered viable infants before their SCAD, a large proportion of them had normal spontaneous vaginal deliveries, but 20% had C-sections. So when we're trying to better understand why it even occurs and why it's so severe, it's probably multifactorial with both hemodynamic and hormonal components. Interestingly, as noted in the other studies I showed you, it most often occurred early on postpartum as compared to other phases. We recently updated this data and presented at AHA this past year, 128 patients, and found very similar findings. About 5% actually had their SCAD during pregnancy, but of the 121 patients with postpartum pregnancy-related SCAD, 72% were within the 12 weeks of delivery. Mean age was 35. Presentation was a little less STEMI in this group. We also included non-STEMI, but we hypothesized that we're better at identifying SCAD now as more people are aware of it. Left main and LAD were common sites, and about 1/3 still had multi-vessel SCAD. And looking at 3 years follow-up, about 9% had another SCAD, over half of which occurred within that first year postpartum. So some important points there. There were no deaths. A common question is, what about pregnancy after SCAD, particularly since it's associated with pregnancy? We did a series back in 2015 of 8 women who had a pregnancy after SCAD, and this is just kind of the time course of how they did with details. And essentially, 1 woman did have a SCAD recurrence at 9 weeks postpartum following a normal spontaneous vaginal delivery. Her first SCAD had nothing to do with pregnancy. She also did not have fibromuscular dysplasia. So it was hard to understand why she was the person who had the recurrent SCAD. Since that time, I've since followed up with her, and she's continuing to do well. And then as part of that follow-up, we decided to relook at our registry to update that data, and recently published a study, and we approached the data a little bit differently. We looked at 990 women with completed surveys in our registry, as well as abstracted records, and we focused on all the women who were childbearing age. And we did 3 analyses to really try to better understand the risk of pregnancy after SCAD. We did a cohort time to event analysis, including 636 patients, a case series of 23 women, and then we also did a nested case control focusing on recurrence, matched to patients without recurrence to see if there's any difference in history of pregnancy. With cohort study, we did find a 5-year recurrence rate of about 14.8%. And really just looking to see if pregnancy was associated with that, we did not see an association. And that was also adjusting for other factors as listed there. When we looked at the 23 women we had in kind of our case series version of this study, there was a total, among them, a total of 32 pregnancies after SCAD. The median age at time of pregnancy was 38 years, and 2 women did have a recurrent SCAD, one of which was actually one of the women in that first series I just highlighted to you, because we did follow up with all of those women. And then the other was a patient who had a pregnancy after SCAD, but her recurrent SCAD wasn't until many years later, about 4 years, I believe. And then when we did the nested case control, there was really no difference in regards to the patients with recurrent SCAD versus those who did not in regards to exposure to pregnancy after SCAD. So the conclusions from that study was that most women tolerated pregnancy and lactation after SCAD without evidence for increased risk of recurrence. And this study suggested that there's probably multiple contributors to SCAD recurrence. I encourage you all to interpret these results with caution because there's a selection bias, a small total number of women who did become pregnant after SCAD, and there's a lot of unmeasured confounders. For instance, all these women had normal ejection fraction at their time of their pregnancy, and we know from other risk calculators that ejection fraction is a large predictor of how people will do later. the hemodynamic and hormonal changes that occur with pregnancy, the severe presentation of pregnancy-associated SCAD, which I just reviewed with you, and the lack of preventative strategies for recurrent SCAD or other complications are really reasons that we still in clinical practice discourage pregnancy after SCAD. However, with that said, if a patient is pregnant after SCAD, it does not definitely mean that they'll go on to have more SCAD, is essentially what we have found. So some take-home points. SCAD is an important cause of acute coronary syndrome in women. It occurs due to hematoma and or due to the tear of the coronary arteries. Pregnancy-associated SCAD tends to occur early postpartum. That's the most frequent time we see it. And there's a lot of theories as to why that I won't get into. PSCAD does have a more severe presentation. It tends to be more proximal vessels, left main, LAD involvement, multi-vessel involvement. And pregnancy after SCAD is discouraged, although there are likely multiple factors that contribute to complications such as recurrent SCAD. This is just a lot of the contributors to our research program, because I did show you some data from the hard work of these folks. I thank you for your attention, and I will be looking forward to answering some questions. And now I'll stop my share to hand it on to our next speaker. Thank you.
Wow. Thank you so much, and this was very informative. I will ask now Dr. Sharma to give us her insights of what are the key adverse pregnancy outcomes that we should keep in mind, and exactly what would be their long-term cardiovascular risk. Thank you, Garima. You're on. We can see your screen.
Can you see me now?
Yes.
Okay, perfect. Thank you for this opportunity, and great talks, Dr. Mehta and Dr. Tweet, and this is fantastic. So I am going to talk a little bit about adverse pregnancy outcomes and their associations with long-term cardiovascular risk. The two main objectives really describe the pathogenesis and changes in the cardiovascular system with APOs, and then talk about cardiovascular risks associated with APOs, and talk a little bit about prevention in the postpartum timeframe. So what are APOs? You know, adverse pregnancy outcomes occur in about 20% of pregnancies, so they're not uncommon. And although they are separate diagnoses, they're really a cluster of separate diagnoses that have very common shared pathogenesis, and the answer is in the placenta. In addition to potentially life-threatening complications, they actually are associated with significant long-term cardiovascular risks. And I like to think about APOs having, stepsisters. And so HELP syndrome is a stepsister of preeclampsia. So really briefly, preeclampsia is de novo hypertension that develops about 20 weeks or after during gestation with proteinuria and with evidence of some end organ damage, either convulsions or seizures or renal failure. And gestational hypertension is, a seemingly benign sister, which does not have proteinuria, but also occurs about 20 weeks after pregnancy. Preterm birth or preterm delivery is a spontaneous or indicated. Sometimes preeclampsia is associated with necessitating preterm delivery. So spontaneous or iatrogenic preterm delivery before 37 weeks. And there's a very specific form of preterm birth, which occurs early preterm, which is before 34 weeks, which is even more associated with strong cardiovascular events. Intrauterine growth restriction, which is small for gestational age baby. And then the HELP syndrome, which is the more profound malignant form of preeclampsia associated with hemolysis, elevated liver enzymes, and increased bleeding can be very catastrophic to these women. And then also like to think about peripartum cardiomyopathy as a branch form of preeclampsia. There is a phenotype of peripartum cardiomyopathy now that we're recognizing, where you do not really have significant LV dysfunction, but very, very significant diastolic dysfunction and evidence of pulmonary edema. So you'd like to think about this as a cluster of disorders, which are not actually that uncommon, and can really create a lot of problems for women. So what do we know about them, and how are we thinking about pregnancy hospitalization? So this is really good data that came out a couple years ago that looked at delivery hospitalizations and the existing types of cardiovascular disease. And while congenital heart disease and valvular heart disease and cardiomyopathy and pulmonary hypertension were still the significant predominant form of cardiovascular disease in pregnancy, it is recognized that hospitalizations of women with cardiovascular disease increased in the time frame, and this is data from the national inpatient sample from 2002 to 2012. But in that data, it's also very clear that the prevalence of hypertensive disorders of pregnancy and preterm births also increase. And like Dr. Khurram Nasir pointed out, this is not an insignificant problem. It causes significant morbidity and mortality to women. About 16% of pregnancy-related deaths are predominantly from just hypertensive disorders of pregnancy. So one must recognize the burden of disease that we have. So how are we thinking about cardiovascular disease in pregnancy? Very, in briefly, there's been a paradigm shift. In order to sort of understand this, we must also look at adverse pregnancy outcomes as a type of cardiovascular disease in pregnancy. And they have, significant pre-existing risk factors, which have very commonly associated with traditional risk factors that we see in cardiac disease. And a very common shared mechanisms. So these women usually tend to have either chronic hypertension or dyslipidemia or maternal obesity, pre-pregnancy obesity, and a cluster of risk factors which are very similar. And for some reason, there is placental abnormality during pregnancy that causes an APO. And I'll talk a little bit about that. And then they're sort of present with an APO, and we believe that then there is a strong association between what happens during pregnancy and what may change in the vascular endothelium, what may change in the arterial compliance, what may change in the cardiac mechanics of these women that presents then with early onset overt cardiovascular disease. So I put this in just to kind of give a sense of what may be happening in terms of pathogenesis of preeclampsia. It's widely recognized that it's because of impaired placentation, which causes hypoxia. And that really manifests itself in the form of multi-organ failure. There is one thing that one must recognize is also my area of research is this biomarker, which has got FLT1, which is a soluble FMNs, which is really something that inhibits vascular endothelial growth factor and causes placental insufficiency and changes the angiogenic milieu of the placenta. That's sort of is believed to spill over into systemic circulation and is strongly associated with the multi-organ dysfunction that we see in preeclampsia. Again, there's a lot of normal and abnormal physiological changes that happen during pregnancy that can present in a APO. We must recognize that in an APO there can be, especially in hypertensive disorders of pregnancy, there can be increased SVR, increased mean arterial pressure, decrease in cardiac output, and that can really affect cardiac hemodynamics and cardiac function during pregnancy. There has been recent data looking at echocardiographic manifestations of preeclampsia, which we won't have time to get into. So what about preeclampsia and future cardiovascular risk? This is one of the largest meta-analyses, about 22 studies from 2005 to 2017, about 6.4 million patients, including about more than 250,000 women, that really looked at women with preeclampsia followed from 6 weeks to about 39 years of follow-up. And what they found was that preeclampsia was strongly associated with cardiovascular death, coronary heart disease, heart failure, and stroke. But herein lies the problem. The highest risk is actually associated in the 1 to 10 years postpartum. And I want to focus on this because this is not really the time when these women usually interface with cardiologists or primary care doctors or preventative cardiologists. Many of these women are actually lost to follow-up and are not being seen in the postpartum clinics. They are actually preeclamptic, have had a baby, continue to have other associated risk factors, and then have full-blown cardiovascular dysfunction early, about a decade earlier in their life. Again, this is also data that recently came out of JACC from the MGA group that looked at hypertensive disorders of pregnancy, which is both preeclampsia and gestational hypertension, as well as chronic hypertension with superimposed preeclampsia, strongly associated not just with coronary artery disease and heart failure, but also arterial aortic stenosis and mitral regurgitation and just valvular dysfunction overall. So something to sort of bear in mind when we see these patients. How about preterm delivery? This is a very large national cohort of preterm delivery that came out of the Dutch database that looked at the timing of preterm delivery and its association with ischemic heart disease. Earliest preterm delivery was associated with the strongest ischemic heart disease. And this is after controlling for underlying confounding cardiovascular risk factors, so independently associated with ischemic heart disease. And it's important to recognize that this is happening in these patients. Many of these patients are not being counseled about their associated risks and are not being seen by cardiologists. Lastly, what if you have multiple APOs? If you have multiple APOs, if you have multiple preeclamptic pregnancies, you have preeclampsia with small for gestational age infant along with preterm delivery, obviously your association with cardiovascular risk is even higher. And then lastly, gestational diabetes. Also, gestational diabetes kind of is very, very common. It's depending on your racial and ethnic group, it tends to be more common in an immigrant population. It tends to be definitely more common in Southeast Asian population. In fact, recent data from the Indian subcontinent is startling, with about 31% of pregnancies in South Asia having gestational diabetes. It's just mind-blowing that they have this amount of predominance of gestational diabetes, which has very strong associations with cardiovascular outcomes here. This is data that looked at, this is actually from the Cardia study that looked at about 2,700 patients and looked at the associations of any cardiovascular events and coronary artery disease in patients with gestational diabetes with and without postpartum diabetes. Obviously, patients who had gestational diabetes that went on to get postpartum diabetes had the strongest association with cardiovascular events. But right here, the blue, the worm here that has gestational diabetes with no postpartum diabetes is not benign. So that in itself is also something that we should be counseling these patients postpartum to change their trajectories. So lastly, APOs are not benign. They're not benign. We don't really engage women in pregnancy histories. I think it's very important to ask a woman of childbearing age if she's had a recent pregnancy about preterm delivery, hypertensive disorders of pregnancy, about gestational diabetes. These are not benign. Identifying their long-term risks, like really engaging them in a conversation about health education and health promotion is really important. We know a lot about associations. We don't really know about causations. And I think it's really important to recognize that while we know that APOs have a strong cardiovascular risk, we really have to do more in terms of precision medicine to understand what exactly changes in the postpartum timeframe that increases their the likelihood of developing cardiovascular disease postpartum. With that, I will end. Thank you, and I will give it back to Khurram.
Thank you so much. This has been a fantastic overview, looking at one of the major issues that we deal with, what to do with the lipids, adverse pregnancy outcomes, and at the same time at the spectrum end of not forgetting some of the more of the rare complications. So I'll start just general questions where the feedback I've received from primary care and general cardiologists. For example, Dr. Mehta, of course, we understand patients you spoke about who already have familial hypercholesterolemia and their management, but what are the guidelines and recommendation for cholesterol screening in non-FH patients, and at what stage would you do that? And if you find elevated LDL, what to do?
Sure, that's a great question, Dr. Nasir. So, the guidelines, regardless of gender, is at least by age 20 to having your cholesterol screened. Certainly, if there's a family history of FH or premature cardiovascular disease, screening in adolescence is good. So 20 would be absolutely necessary. But what we find out is many patients don't get it done, either through their primary care or they choose not to get it. Some patients, though, now with the changes in healthcare, their companies are doing it, right? So they're getting some sort of preliminary screen. But if a patient has not had it and it's a female, I think it's fine to check while they're pregnant. And that's okay. I mean, it might for some women that may be their only contact with a medical professional is during pregnancy, and so it's essential to screen because of the 1 in 250 percentage prevalence of the disease of FH. In terms of the when to treat their cholesterol, it depends. So obviously, if their LDL is greater than 190, you would treat. If they're diabetic, you would treat with cholesterol medications. But let's say they're in the 130s to 160s range. That's really where we focus on the lifestyles and really push lifestyle interventions on these patients.
Great. So, Dr. Sharma, we see in our clinics these days there is huge referral of hypertensive patient in pregnancy. Now, should we treat them differently than general hypertension? Any data on new drugs, and which one would you recommend and why?
Yeah, that's great. The ACOG definitely has certain guidelines for treatment and cutoffs of hypertensive disorders of pregnancy. They allow a little bit of more permissive hypertension in pregnancy. We don't want these numbers to be very low as we're used to controlling, patients that are not pregnant, primarily because we're worried about uteroplacental insufficiency and drop in placental circulation. However, having said that, hypertensive disorders of pregnancy can be catastrophic. So if you're seeing a patient who has preeclampsia, or you're co-managing a patient with preeclampsia, it's really important to enable these patients to be able to take their blood pressure at home. Having the access to a home blood pressure monitor to be able to check this at home, giving them valuable information about the signs of stroke. Peripartum stroke is very high in these women with hypertensive disorders of pregnancy, especially the ones that present with postpartum hypertension, which is a rare form of preeclampsia. These women don't really become preeclamptic until they deliver or the week after their delivery. And then really the first time they come into the hospital is when they're having a stroke. So having that conversation about the signs of stroke is really important. There is a lot of talk about what kind of medical therapies we should be using in women with, that are pregnant. Obviously, ACE inhibitors and angiotensin receptor blockers are sort of contraindicated because of fetal complications associated with them. But most calcium channel blockers are very well tolerated. And in fact, there was a very large study that came out in the Lancet last year that looked at about 12,000 patients. It was done in India. Then they looked at the primary endpoint of controlling hypertension during pregnancy and getting good blood pressure control. And they looked at labetalol and alpha-methyl-dopa and nifedipine. And we must recognize that most of us probably don't use alpha-methyl-dopa, but in large resource-limited countries, that is actually the primary drug in many, many countries. And what they found was that the reduction of primary endpoint of maintaining a blood pressure less than 140 over 80 in these pregnant women was most achieved by nifedipine. So it's really coming upon as becoming one of the first-line agents in controlling hypertension of pregnancy and should be really widely used. We also get asked about labetalol and beta blockers in pregnancy. Generally, labetalol, very well tolerated, propranolol, very well tolerated, metoprolol, well tolerated, atenolol associated with IUGR and should be held for the most part.
Thank you so much. Dr. Tweet, thankfully, we don't get to see too many patients with SCAD, and that's great. But most of these cases that occasionally that comes up are during the postpartum period. And of course, one of the key questions, especially going on, let's say, post-stenting on DAPT or some of the other medications, the question that really comes up, and I'm sure you must have gotten that a lot, what about breastfeeding? How does that affect that?
So believe it or not, a lot of those cardiac medications are safe to continue while breastfeeding. So most patients we encourage to continue breastfeeding. Of course, we review all the medications and discuss risk, benefit, and those sorts of things. The only concern I sometimes have is there was a subgroup of patients who had pregnancy-associated SCAD in the postpartum period who noted the onset of their chest pain that started the beginning of their SCAD symptoms, so to speak, that brought them to the hospital, at which time they were diagnosed with their MI. Some of them noticed it at the time of lactation, and whether or not there's an association there, we don't know in terms of causation. As mentioned already, association versus causation. But anytime we start having a patient running into issues with angina after their SCAD, particularly if they in any way describe it in association with lactation, we usually encourage them not to breastfeed further and to find other options such as milk donors or formula or whatever they're comfortable with. And so it ends up being a very individualized conversation with some nuances.
Well, thank you so much. So, Dr. Mehta, just curious, any concerns or things that we need to watch for lipid-lowering therapies during the time period of breastfeeding, postpartum for these patients?
Sure. I mean, at this point, the guidelines say still you're holding statins till after lactation. I think that might change in the near future, especially if this kind of falls into Dr. Sharma's wheelhouse, but there are some studies, preliminary studies on looking at preeclamptic patients and the usage of pravastatin to maybe reduce preeclamptic events in subsequent pregnancies, and the lack of teratogenicity with pravastatin. So that might be in the future down the pipeline that we'll be seeing, and that may be calming for our patients. But at this time, it's the bile acids questions which patients don't really tolerate. And I've had, actually this summer, I had 2 patients that had FH, were pregnant, and we actually had to initiate LDL apheresis on them and closely monitor them through pregnancy as well as during their lactation. So not many options yet for pregnant women.
Quick question, PCSK9 inhibitors. What do you think during the pregnancy and post-pregnancy?
We just don't have the data yet. There is that registry that's coming about where women have inadvertently gotten pregnant while on the PCSK9. So that'll be telltaling. It just depends on, can we really get FDA approval on that? And as we all know, that may take some time with the way the FDA has to clear things. So I'm not sure I can really promote PCSK9 at this time.
So and again, just getting your sense, considering monoclonal, very much targeted applications, and what can we learn from other prior monoclonal antibodies from that, whether they have been approved during the pregnancy, have they been safe? Where do you think this will head out eventually?
I think eventually there might be a certain population that it may benefit. I think that those kinds of options we're really going to reserve for the homozygote FH or the secondary prevention patient who's already had an atherosclerotic process that would benefit from it. It might be just, and that might be the right population. And I'm not promoting LDL lowering for all pregnant women. It's just those that are just at the higher risk. And the other issue is many women come to us saying, I'm planning on getting pregnant, but it may take months and years, and that's a lot of years of having high LDL. And so that's where we have to kind of think of making some refinements to their management.
Although, if I may add, if the pravastatin trial that's been going on, there's a large NIH trial looking at the effect of pravastatin prevention of preeclampsia, the severity of preeclampsia. If that works for preeclampsia, you may be able to extrapolate that to your FH population. At least pravastatin, if anything, may be effective. So it's a multi-center trial, and we're really hopeful that the pleiotropic effects of statins may somehow reduce inflammation in preeclampsia. We'll see.
So it'll be helpful for the secondary prevention patient, but not necessarily, and maybe some of the heterozygote FH, but certainly not for the homozygote FH. That's like a drop in the bucket for them.
All true. So since you were talking about preeclampsia, I know that I'm sure that the hypertensive management is going to extend into the postpartum. Any concerns from a breastfeeding standpoint?
No, not really. Other than ACE inhibitors and ARBs, which are actually, the likelihood of them creating significant problems postpartum are very rare. They're still sort of not encouraged, but all of the other classes, hydralazine, beta blockers, calcium channel blockers, I mean, whatever else that we can do, we will do. And there is a subset of women, especially the ones that, at least the ones that I have seen in my practice, that have postpartum hypertension or postpartum preeclampsia, typically are on at least 2, maybe even 3 antihypertensive, and they just have a very different fulminant form. And the theory of placental insufficiency doesn't necessarily hold true in them, although anti-angiogenic milieu may still. And there's a lot of data out there that we just don't know, why they have it. Should we be encouraging these women to continue aspirin postpartum just a little longer to prevent these postpartum preeclamptic episodes? We just don't know. And right now, we don't recommend that.
Okay. So shifting gears, Dr. Tweet, with these SCAD patients, breastfeeding gets no issues as far as continuation of the medications, but a challenge that may come up is future pregnancy. I know that you just mentioned briefly about the risk for SCAD in the future pregnancy, but practically, how do we counsel these patients, and what are the pros and cons and items that we need to think about during the shared decision making? And if they decide they want to get pregnant, how do we manage them?
That's an excellent question. Thank you. And probably I could talk about it a long time, but I'll try to keep it brief. Usually what I do with my patients is I just share with them that there's a lot of unknowns, but I do share with them the data that we do have. So very similar to the information I shared with you all tonight. And believe it or not, because those were small studies, but that's kind of all that's out there. So, I tell patients that. I also often incorporate some of the data from just pregnancy-associated myocardial infarction too, and also incorporate, some of the CARPREG and the Zahara study information, although that was not specific to SCAD, and those have some limitations in of themselves. I generally very strongly discourage pregnancy after SCAD because of the other reasons being, if someone did have, for instance, a postpartum SCAD, it does tend to be more severe. And because we don't know really how to prevent SCAD, at least at the current time, maybe with future research, we will be able to, and that will change. And because we're not very good at detecting who may have further complications. If a patient is adamant that this is just important to them, quality of life, I make sure that one, I'm having the discussion with both them and their spouse so that they're both 100% on board with how we proceed. 2, I do make sure I understand what their baseline left ventricular ejection fraction is, for instance, because that will significantly affect risk. Whether or not they're still having symptoms, whether or not they're having arrhythmias, that will all be incorporated into their personal level of risk. What their FND status is, so for instance, if they have an aneurysm somewhere, that certainly will add to their risk and how I counsel these patients. And then I really tried to, early on, even before attempts at conception, I involved our maternal fetal medicine colleague to really discuss with them, again, from their perspective, risk and how we would proceed with monitoring and so forth. And essentially during the course of the pregnancy, really have a team of specialists, both cardiologists, maternal fetal medicine, and then also incorporating the input from anesthesiology, because essentially what we would do is closely follow these patients through pregnancy, but then really aim in terms of timing for delivery we often try for vaginal delivery if possible, unless there's a contraindication to that. And many times we'll induce just so that we kind of have a clear time and date. And then we try to aim to have delivery at kind of a level 4 center so that if an emergency occurred, we would have all the resources available. And then also try to aim for good pain control. So there's not as much, strong Valsalva, usually aim for neuroaxial anesthesia. And sometimes we also do, for instance, with vaginal deliveries, an assisted, operative vaginal delivery, such as with forceps, to minimize the amount of Valsalva and pushing. And we have these discussions. We kind of work with each patient individualized. This doesn't happen commonly, obviously. So when it does, it really does have to be tailored to that individual. But many times we can have very successful outcomes working closely with the patient and their family and our colleagues.
Oh, thank you so much. As you were just detailing, a thought came to my mind. We also are seeing a rise in the intracerebral hemorrhages during the pregnancy, and seems like third trimester, usually 12 weeks after birth, rate is almost 4 times than in the control period. Is there any relationship with SCAD?
Not that I'm aware of, but we'll pay attention to it. I haven't noticed a trend in that. So I think that's an excellent question, though.
So
yeah, I think you're right, Dr. Nasir. There has been an increase in peripartum stroke as well, mostly bleeds, and I think many of them are in women with poor controlled postpartum hypertension, which is why I think having at least the ACOG is really pushing for women to have extended follow-up. It's pushing for women to have close follow-up, and in fact, the ACOG committee bulletin that came out on hypertensive disorders of pregnancy requires these women to be seen within the first 3 weeks of delivery, not waiting until 6 weeks postpartum to be seen because of the rise in these strokes. So it's definitely a concern.
Dr. Sharma, is any of those bleeds related to the patients being on aspirin for their preeclampsia? Has there been an association?
Not really, because usually we stop it's who knows, right? We stop the aspirin at about 37, 38 weeks. We started at 12 weeks and we stop it. And for the very same reasons, when they're undergoing a vaginal delivery, we don't want any other complications with bleeding. So technically, aspirins are kind of already out of their system. So I think this is purely happening because of unrecognized risks that these women have, largely contributed by hypertensive disorders.
And in regards to SCAD, if anything, we are more concerned about like vertebral dissections or carotid dissections as a potential cause for stroke. And a lot of them, especially with the cardiac medications, tend to be a little more on the hypotensive side. There is a proportion who do have preeclampsia, but typically with the cardiac medications end up being pretty well controlled from a blood pressure standpoint. So we don't necessarily see that as much. The other thing I'll add, though, is not commonly we will have pregnant patients on anticoagulation or even, for instance, Coumadin, and then thinking about bleeding in the brain. That might be a situation if a woman is on Coumadin and needs to deliver, that would not be a situation for vaginal delivery, even though it's otherwise usually preferred due to concern for brain bleed in the infant. So that might be an exception to the preference of vaginal, or that would be an exception to the preference of vaginal delivery.
Dr. Mehta, I just want to share with you a case. We had a 20-some-year-old female on high-dose statin, genetically diagnosed FH, wanted to get pregnant, took them off statins, bile acids, sequestrant therapy, still LDLs elevated. When would you escalate to apheresis? And by the way, we also did a CT angiogram, younger side patient, no plaque. Now the question in that scenario, would you even consider any therapy, or would you have more flexible goals? So how does this role of subclinical athero fit in your decision making for escalation of therapies in these patients during pregnancy?
Sure. So for during pregnancy, I would look at if it's a primary preventative patient, then if it's a homozygote FH, I look for LDLs greater than 300 is where I would put them through apheresis. Apheresis is not an easy thing to get women to do. I mean, we're asking them to come in twice a month or every 2 weeks to do this. They're already feeling miserable with the pregnancy. The complication risks of line infections are there and not negligible. One of the things that we saw this summer was the hypercoagulability of these pregnant women. So their lines or their IV access sites were kept clotting off. So it's not a negligible risk to put these women through. I would say that their LDL has to be greater than 300 for primary prevention, and if it's secondary prevention, an LDL greater than 200. So in your case with a calcium score of 0, I would let them ride a little higher. I would try and encourage the diet as much as possible, but we know that's just a drop in the bucket for true FH patients. But then also having the discussion of how long they really want to lactate afterwards is essential as well. And, encouraging them to store milk so that they can end a little bit earlier perhaps is key.
So just to carry on the conversation on subclinical atherosclerosis, Dr. Sharma, we had this interesting paper recently suggesting that significantly higher proportion of early atherosclerosis in women who had a history of preeclampsia. Now, how should that change the practice, especially for these women? Do you suggest early screening? It sounded fascinating. Just wanted to hear your thoughts. How do we take into account these young women, and when should we start screening early for them?
I knew you would ask me that question, and it considered me the guru of Power Zero. So I think it's very valuable to understand what the study showed. And for those who are not familiar with it, it is an international study that looked at women who'd had preeclamptic pregnancies. They looked at women from the age of 40 to 63 who had a history of preeclampsia, and they compared their coronary calcium to age-matched cohorts who were normotensive. And what they found in the subset of 250 women was that the women who had preeclampsia developed early coronary calcification about 5 years earlier than their age-matched normotensive cohorts, and the highest likelihood of having any calcium in their coronary artery was seen in women who were aged 45, as compared to their normotensive cohort. So and this is after controlling for underlying confounding risk factors, obesity, hypertension, chronic hypertension, and all of that. And it's to me, it's really, for the first time, we have something that is telling us that early calcification occurs in preeclampsia as early as in their 40s. We really have not had that kind of data. We've had data looking at women who are in their 50s and 60s with increased coronary calcification, but at the time they've had other risk factors with them. So I think it's powerful data. I do think it will be practice changing if we can see this in a longer, bigger cohort. I don't know if the guidelines will really be excited about, and you know this better than I do, will be excited about talking about this, but it really talks more to me about extended screening in these women. This is not a very high risk test. This is not a very expensive test. You're not exposing them to tons of radiation. But if it gives you an assessment of their overall atherosclerotic burden as early as their 40s, I think it could be a game changer in these women who otherwise are not being even screened.
No, the one takeaway is at least we truly as a health system need to take preeclampsia very seriously, and it's not just it ends with the pregnancy. Actually, the prevention starts from there. Dr. Tweet, I know we spoke about SCAD in pregnancy. It's not limited to that. You're going to see patients who are non-pregnant versus. Is there anything specifically different that you would suggest in the acute management if you were pregnant versus not?
Yes, so there are some nuances and differences, and for the postpartum patient, many times you manage them very similar to a non-postpartum SCAD patient, but then for the pregnant SCAD patient, obviously the situation changes. At the end of the day, you get a team, so a maternal fetal medicine team or OB team should be involved pretty early, but the first priority is really to focus on the mom, stabilizing the mom and caring for the mom. Radiation exposure from a diagnostic angiogram is really minimal, even to the fetus, and well beyond, the concern for the limits. So that should not be a reason not to do standard of care management. So standard of care for a pregnant woman, including medications, if there's concern that the woman is decompensating to the point where all of a sudden you're doing CPR, if you're doing CPR at like 4 minutes and you're at a viable gestation, like over 23 weeks, that would be a time to consider an emergency C-section. If you're considering an emergency or urgent cabbage, because fetal mortality is so high at that point, as high as 38%, sometimes you'll proceed with an urgent or emergent C-section and then proceed to a cabbage. These are all very high intensity, quick decision-making sorts of situations. certainly, if otherwise you would try to, if the woman is stable, for instance, and say 15 weeks pregnant, you'd stabilize her through that. And then depending on where you're at with pregnancy, ideally, you wouldn't deliver until 2 to 3 weeks after the heart attack. And then, of course, depending on what treatment was, with SCAD, we try to conservatively manage, but sometimes do need to place stents. Options for neuraxial anesthesia, such as an epidural, might be limited depending on what someone is on for, in regards to dual antiplatelet therapy and Plavix. So there are some nuances in decision making that need to be made at the moment that are different if you're dealing with someone who is pregnant at the time of their SCAD. And unfortunately, as I showed you, they do tend to be more significant cases with left main or LAD involvement, more cardiogenic shock. So you really do have to get your team together and walk through things relatively rapidly while prioritizing the mother's health, but trying to have a good outcome for both.
Wow. So as we are getting to the end of the hour, this has been a fascinating discussion, and thank you so much. I learned a lot. And more than that, as I start thinking, it's very humbling to think about the scope, but more importantly, the complexity of and the challenges that these specialized care need. And the question really that is, and I look around, we don't find much multidisciplinary specialized care for the, I would say, antepartum, peripartum, and postpartum. And I know Dr. Mehta, and of course I like all of you to comment on that, is this whole concept that all of you are advocating, this pregnancy heart team. How do we get it initiated in health systems, and how do we get the competencies incorporated during our training? Is it cardiology? Is it medicine? How do we get to a point where, as I listen and I'm humbled that even as someone who specializes in preventive cardiology, these are nuances and challenges that are a little beyond my expertise, and I can think how that would play downstreams. How do we close these gaps? And so everyone, I would love to have a closing comment, and again, thank you so much for joining.
Thank you. I would say that you have to first think of it, even the idea of the concept, and then having the collaboration and reaching across the aisle and understanding the complexity, that there's no one answer to it, and discussing these cases is quite key. So moving your organization to do that is essential, and having case-based discussions is essential. But in terms of how to make it happen and how to incorporate it into the curriculum, I'm going to defer to Dr. Sharma, because she has been the lead author on a paper with me on this very topic. So I defer to her expertise on that. So thank you very much.
It's a great question, and I think there is no direct answer, but there is maybe a simple answer. It just takes will. You just have to feel that this is something that you're committed to, and you have to find a partner from OB or from MFM or from primary care, some champion, like a physician provider champion. Health systems will not recognize this usually as a money-making field. This is not that brings in clinical trials. This is not, we're not rich. This is not cardio-oncology. But it is improving the life of significant portion of the population and of mothers. And I think as a society, if we are truly committed to health equity, I think we have to start with our moms. And to talk about how to train, I think it just has to come with commitment at the level of maybe fellowship program directors or clerkship directors, that saying, having a rotation where trainees are exposed to this is the only way to learn. You learn by seeing, and then by doing, and then by talking about it, just like you have provided this a platform so that, people actually take away some learning from this and maybe think about this more. I think it just starts with small steps.
Perfect. Thank you so much. Dr. Tweet, your thoughts?
Yes, I was going to say thank you for hosting this and inviting us to speak on this topic, because this is one way of doing that, and you've clearly accomplished that. And I again, thank you for the opportunity to participate. I really enjoy teaching our trainees, our residents, and our fellows. And anytime I'm invited to give them a conference lecture, or even when I'm on service, they hear all about SCAD and hypertension and heart disease and those sorts of things. So I think little by little, it infiltrates our education. But then you find that they're going on and teaching others, whether they graduate and go somewhere else and become a champion at their local institution, or even if they bring it on rounds, up on rounds with another staff and make that staff start thinking, wow, where'd you hear that from? Or I might look into it further. But then also just the collaboration and collegiality, both with those who are interested in this topic within the institution, but even outside the institution, and really trying to have a multidisciplinary approach as well, and engaging other disciplines, not only colleagues and staff, but their trainees as well. And I found that rewarding, and it is baby steps. It won't happen overnight, but I think slowly but surely we are making progress.
Well, again, thank you so much for taking the time and spreading the gospel. As Dr. Sharma said, I truly believe nothing's more sacred than our moms, and we need to start paying attention. And I hope that many of our audience who is listening will get that message, and hopefully we can all get together. I see the ACC, the AHA, and hopefully we can bring in all the other organizations and try to find more coordinated efforts. And really, prevention begins at the womb, and that's what we need to take. And thank you so much for your advocacy and championing this cause. I really appreciate it. I have learned a lot, and I'm sure all the audience who attended would share the same sentiment. Thank you.